all today. I'm just going to basically give you a high-level view of my PhD research, and then I'm just going to touch on the importance of policy and strategy to research, and then I'll move on to how I adopted and adapted the original research to flex around the healthcare priorities and demands at the time. So in terms of the rationale for the research, well, we know we have an aging population, we have people living much longer, the number of centenarians are set to increase. There is evidence of increase in frailty and complex health and social care needs in the community. And the combination of that and the demand for acute hospital care meant that there was a gap in terms of how we delivered care in the community and reduced the demand for ED presentations and unplanned hospital admissions. And so my research looked at developing a community virtual ward model. This was introduced in North Dublin. It was predominantly focused on admission avoidance and to support older people with complex health and social care needs at home. And it was for people who were experiencing either functional decline or an acute episode, and to be able to provide early intervention and emulate aspects of hospital care in the home, but look at how we leverage validated risk assessment tools to determine if patients were more likely to remain at home or the risk of institutionalisation was very high. This was sponsored by the Nursing and Midwifery Planning and Development Unit in North Dublin, and it was completed with the Royal College of Surgeons Ireland School of Nursing and Midwifery. So the research aim, we looked at unplanned hospital admissions and ED presentations, but it was also to look if we could determine potential outcomes at an earlier stage. And there was a number of data sources used. We looked at demographics, their level of frailty, the types of events that they experienced, the types of interventions, the number of health and social care professionals involved, including public health nurses, but GPs, specialist gerontology, and any social risks, so if they were living alone, if there was evidence of self-neglect. And data was measured over a number of time points, with the maximum being at 90 days. And we looked at if they remained at home or if they were institutionalised. The model of care very much focused around the patient and family being at home. It was overseen by a clinical case manager who worked end to end, so worked with the acute hospital, worked with the GP, specialist gerontology, primary care and community services, and there was out-of-hours service support through the community intervention team. There were 3 virtual wards, and these were dependent on levels of risk. The beds are virtual, so patients are at home. There was between 25 and 30 beds across these levels of risks. The red virtual ward was for patients who were very high risk. They'd had an event in the last 30 days. Amber was moderate risk, so if this was more than 30 days, and it was more a gradual decline. And the green virtual ward was basically patients were transferred to this ward when they were being prepared for discharge, and this was working with the primary care team who would follow up once the patients had been discharged. The study results showed a reduction in unplanned hospital admissions and ED presentations, and these were significant. There was evidence of a reduction in the number of adverse events. There was evidence of admission avoidance, evidence of better integration of care across hospital and community, and also the time to reach a level of stability was correlated to outcome. So if it took longer to stabilise the individual for more than 30 days, their outcomes were generally worse. And they had better outcomes if we reached a level of stability within the first 30 days. We looked at transitions of care, so the types of events and types of interventions. Once there was a behavioural component to care and a severe level of frailty, their outcomes were normally worse, and again, the number of episodes. So if they had 2 or more episodes and they had between more than 7 healthcare professionals involved, these were indicators of a worse outcome. But the unique value of the model of care was that integrated approach. It was that end-to-end. Very much we were looking at admission avoidance, but we also supported egress from the acute hospital. And we offered early supported discharge, so we were targeting interventions to help people come out of hospital earlier, and also looking at admission avoidance. And the care was very much community-based. We offered subacute interventions, so subcut fluids for if there was evidence of dehydration. We managed end-of-life care, so palliative care at home. And patients did not need to attend the emergency department, so we did do planned admissions, And when we looked at an escalation pathway, so a planned admission through the day hospital to a specialist gerontology ward, their average length of day was between 15 to 20 days, whereas previously we did an audit and it was around 70 days for a hospital admission if they went through ED. I'm just going to touch briefly now on policy and strategy in the context of, because this will actually set the scene for the next part of this presentation. So when we look at policy and strategy, the difference with policy is it's very much looking at health goals. It's very much looking at the decisions that we need, the plans and actions, and it clarifies what the values of the policy will be based on. So what's the vision of the future? What objectives and priorities do we need to establish? Setting targets and milestones. An example of a policy was the development of the graduate advanced nursing midwifery practice. And this was looking at how we could create a critical mass of advanced practitioners and the credential and pathway that was required. So it looked at the model of education, the model of supervision, those targeting those healthcare priorities. And strategy is the plan. It's the plan of action. It supports policy and includes the key steps that need to be taken and the critical changes to deliver these over a period of time. An example of this is the maternity strategy. It maps out the future for maternity and neonatal care, and that care will be delivered in a safe and high quality perspective. So why is health policy and strategy important? When you're looking at your own research, it provides the direction. So what are the priorities? Where are the gaps and the demand? It helps you align your research to deliver on the key priorities, but it also supports the research development, so that investment, engagement with your organisation, endorsement by your peers and support in terms of organisational support. And it provides an opportunity for you to influence or change policy, and it can assist in identifying gaps, and it provides that opportunity to influence and change policy following your research findings. So I'm just going to touch on now how my research was adapted and adopted to inform policy. So at the time of the publication of my research, the Sláintecare strategy and policy was published. And this was very much about how we base our care on need and not ability to pay. But it was very much focused on that integrated approach and moving away from a hospital focused and very much shifting care to the community. So how we could reduce demand for acute hospital services and deliver care closer to home. And at the time of my research publication, we had a new nursing role. It was the enhanced nurses role. And this was very much, again, about supporting a shift in community-based care to enable the delivery of Sláintecare. The publication of the advanced practitioner policy as well, so that we needed to create a critical mass, but not all advanced practitioners were going to be community-based and with an acute hospital base. And then we had the pandemic, so we needed to change how care was delivered and maximise on leveraging digitally enabled solutions. So the Department of Health were interested in how the CVW model could be adopted and adapted to support the enhanced nurses role, particularly around capability framework, to reduce the demand for hospital care and particularly address unmet need. And so it was actually tested looking at patients with complex respiratory conditions and how we could mobilise nursing across acute, hospital and community, integrate nursing and maximise on technology using remote monitoring. And the report is accessible on the Department of Health website, and this particular report I led on. So the unique value of the model was considered that it modernises integration, provides that clear, robust governance structure, mobilises nursing across hospital and community, bridges the gap between access and coverage, and it also enables nurses to operate to the top of their licence, and it very much drives Sláintecare. In adapting and adopting the research, so we looked at the previous principles of the CVW model, and then we determined we would test it as a proof of concept. We used objective data, so again, looking at where we could leverage those validated screening tools and how we could use remote monitoring platform. We mapped processes and workflows to define how the model of care would operate. We looked at the governance structure and considered what was realistic that we could deliver on and how it would align to the National Service Plan and Sláintecare. So we looked at admission avoidance, and the referrals were direct from the GP. It was determined that the governance would be under the acute hospital, but supported by a community health organisation. It was delivered by advanced practitioners based in the community, but it was supported by the community intervention team with enhanced nurses, very much part of the team. And the care was delivered using a combination of remote monitoring devices and direct care. It was a shared care approach. Patients received either direct care as well as video-enabled care, telephone support, and we used objective data from the remote monitoring devices and also the screening tools that we used, as well as the direct visits. And there were, on average, 2 to 3 virtual ward rounds with a consultant per week, and there were huddles between the acute hospital and community nursing team daily. The remote technology, we used both a high-tech and a low-tech approach because we didn't want to digitally alienate anybody. There was the average age was over 65 involved in this proof of concept test. And so the high technology approach was the data was Bluetooth directly to a remote monitoring platform. The low tech approach was that the nurses would actually input the information onto the platform, and they would support individuals in terms of how to use the devices. But both the acute hospital and the community had access to the platform, and we could trend responses over time. In terms of patient-related outcome measures, there was improvement in symptoms, self-efficacy, reports of improvements in quality of life, improvements in exercise tolerance, and there was evidence of increased adherence. Patient feedback was excellent. They felt that their self-management, that they'd all learned something new about their condition. That partnership approach and that shared care approach was received very well. Families felt that they had understood more about the condition because of that combination between acute hospital and a community approach. The patients had reported that if they had access to this model, they would be more likely to want to go home earlier if admitted. And they all felt that the technology had helped them in terms of anxiety and stress around their symptoms. So the principles of the research that were applied was that the CVW was actually flexed around the priorities and population health changes at the time. It was community focused. The admission avoidance was a primary driver. Patients did not need to be admitted to ED. GPs referred direct in. It was integrated with the acute and community. We provided intensive monitoring and interventions for a defined period, and we used evidence-based screening tools to measure response and health status over time. And that's the end of my presentation. It's a very high level view. I'm more than happy to engage with people afterwards if they wish, and my publications from this research are available. And as I've said, the report, which I very much recommend that you familiarise yourself with, is available on the Department of Health website. Thank you.